Okay, so we are just giving folks a couple minutes to get in. We only have an hour today, so I'm gonna go ahead and jump into our presentation because we are joined today by Lisa Reville from the Harm Reduction Action Center. So we're really excited to get into all of that. Before we do that, we're going to do just a little bit of housekeeping. So welcome to the next iteration of the Lift Off, I'm sorry, of the Lift Academy. Just a couple of housekeeping things. As you're coming in, you are muted. We will be monitoring the chat box, so please feel free to add any thoughts, questions, chats there. If you want to introduce yourself, if you're just joining us or have been here with us for a minute, please feel free to do that in the chat box. And just a reminder that this is being recorded. We record and put everything that we do with the Lift Academy on our SHG page, which we will share at the end of the presentation. But please know you are being recorded. So if you have any issues with that, feel free to hop off and we can watch the recording later. Um, a little bit about what we're going to do today. So just some basic welcome introduction. And we're really going to spend most of the time hearing from our expert, Lisa, about where treatment and harm reduction can really overlap in the world of homelessness. I think you all are experts in this. You know that there's a big overlap with folks with behavioral health needs and homelessness and substance use. Funders are talking about these populations in a lot of different ways today. So we wanted to just give some basic definitions, explain what we know works and how we know that works, share a little bit about how we can use these options to increase long-term stability for the folks that we're trying to help. And I think Lisa's going to talk a little bit about the state of Colorado, some impending legislation, some things that they're working on, and then hopefully we'll have a lot of time at the end for some really robust Q&A. We all do a short event, a short event evaluation at the end. You will still have your chance to win your gift card if you are able to complete that evaluation. And then we'll share a little bit about what's coming up and some other curricula that we have on the agenda that we are excited about. So with that, I will stop sharing, I think, and give it to Lisa to jump into her presentation.
All right, all right. Thank you so much for having me today. I'm going to, what am I going to do here? I'm going to do this. Sometimes it acts like the slides don't move forward. So let me know if I'm talking a lot, but I'm not moving slides because we got slides to go through, friends. My name is Lisa Rayville. I'm the executive director of the Harm Reduction Action Center, Colorado's largest public health agency that works specifically with people who inject drugs and people who smoke drugs such as crack, meth, and fentanyl. We're going to talk about harm reduction. We're going to talk about syringe access. We're going to talk about how we're in the worst overdose crisis we've ever been in with the most unregulated drug supply we've ever seen. I've got data for the nerds. We're going to talk about the 8 pieces of statewide legislation we've passed and the 4 Denver City policy changes. We're going to talk about where we're at and where we're trying to go. Please feel free to ask questions along the way in the chat. I know Cassie's monitoring that. Better to do it during the way until you don't have to wait at the end, okay? I do speak quickly. It's kind of my thing. You just have to embrace it. Okay. Harm reduction reduces the harms associated with X. Today, we're talking in relation to drug use. However, we use lots of forms every day in every way. Sand in a playground, helmets when riding a bicycle, designated drivers reduces the harms associated through drunkenness. The war on drug users has been incredibly racist and classist since forever, but especially June of 1971. And all the United States has really prioritized has been stigma, shame, incarceration, just say no and dare. And again, that's all that's done is bring us here to the worst overdose crisis we've ever been in with the most unregulated drug supply we've ever seen. We're engaging folks today for a healthier and safer them. There's something positive that folks can do today. With this current drug supply, it's just so incredibly unregulated that prohibition is our problem. Harm reduction isn't, you know what you should do? Nobody knows you better than you know you. How can I support you for a healthier and safer you today? Harm reduction is no place for ego. It's a place to forget what you think you know and set aside your opinion so that when you meet people where they're at, you can take the time to ask them where they want to go. And that was Dylan Stanley. Again, the war on drug users began officially in 1971, but a lot happened before that, obviously. A few years after that, the DEA was established. Last year, the DEA had a $3.2 billion budget and 9,000 employees. They know they can't arrest their way out of drug use. Crack was first developed and introduced in the 80s. Reagan signed the Anti-Drug Abuse Act of 1986, making mandatory minimum penalties for drug offenses. Then, of course, you had the 1995 crime bill, which contributes and contributed to mass incarceration. There have been record amounts of money allocated to the drug war. Now, a little while ago, they did reduce the crack powder sentencing disparity. It used to be 100 to 1. Now it's 18 to 1. A couple of administrations ago, they did declare this a national emergency. They called it the opioid epidemic. We don't call it that. We call it an overdose crisis. And quite frankly, where we're at is a prohibition crisis. There's a common misconception that people who inject don't care about their health. They do. People reaching out for syringe access programs are reaching out for quality health care. For a little while longer in Colorado, we have black tar heroin, which is difficult to snort and expensive to smoke, so you almost have to exclusively inject it. The average heroin injector injects 3 to 5 times a day. The average meth injector once or twice a day. The average cocaine injector 12 to 15 times a day. The average fentanyl injector 10 to 12 times a day. We want to make sure that folks have new sterile equipment every single time to prevent and eliminate the transmission of HIV and hepatitis C. Anytime you break your skin, you're at risk of infection. One swipe of an alcohol pad will keep folks out of the emergency department for costly skin tissue infections. Colorado Hospital Association says we pay out about $6,000 a day for IV antibiotics for a soft skin tissue infection, with an average stay in the hospital for about 5 days that can be completely prevented with an alcohol pad that costs less than a penny. And HIV and hepatitis C are completely preventable with access to sterile supplies. Fun facts about syringe access programs. What we're doing is currently happening in 40 states and 93 countries around the world. I can assure you no one's being revolutionary. There are about 21 of us in the state. There's 3 in Denver, a few in Boulder, 1 in Fort Collins, 1 in Grand Junction, 2 in Pueblo, 1 in Alamosa, 1 in Jefferson County. Weld is trying, stuff like that. But that's probably going to be about it. There's not a lot of glory in starting one, I can assure you. Reduces injection-related diseases such as HIV and hepatitis C, improves public safety. The state health department tells people to put used syringes in a coffee can, wrap them in duct tape, put them in the dumpster. Nobody feels good about that. Ours are incinerated. We know that 1/3 of law enforcement officers nationally will be pricked by a syringe at some point in their career. 2/3 of that 1/3 will be pricked multiple times. It's actually 1 in 5 with Denver Police Department. We have passed 2 statewide laws to promote proper disposal. I need folks coming across town and disposing with us, and to reduce needle stick injuries to law enforcement. So before law enforcement pats me down and asks if I have anything sharp, I say yes. They don't get pricked. I don't get charged. So those laws have been in effect in the state of Colorado since 2013 and 2015. Taxpayer money savings. The average person is living 25 plus years with HIV. It's a manageable and chronic disease. However, it doesn't need to be so. My needles cost a dime. And evidence-based. There's not many more rigorously tested best practices to treat chaotic and non-chaotic relationships to drug use as a health issue and not a moral issue. This is the magnification of a needle before use, after 1 use, and after 6 uses, it starts to curve and shred. When you don't have a syringe access program in your community, it doesn't mean that folks aren't injecting. It means they're using that one on the right. All right, fentanyl is here. I want to make sure you have really good information. There is a lot of misinformation out there about fentanyl. I always say if the drug war had a communications director, she's doing a really great job of getting that misinformation out there. So that's why I'm here today, to get you the facts. Fentanyl is here. It's been in our supply since about 2018. It was started out in the supply in the East Coast about 2014, 2015. Fentanyl is a strong synthetic opioid that's been used in clinical settings for decades. It's partly responsible for the current overdose crisis in the US, combined with a lack of resources and the criminalization of people who use drugs. Heroin is leaving us due to climate change and lack of poppy cultivation. It's much easier to make a synthetic opioid in a lab than it is to deal with farmland and water access. Much like in 1920s alcohol prohibition, they weren't really brewing cases of beer, they're making cheap hard liquor in the bathtub. The only difference is people started going blind and dying and said maybe we should regulate it. We expect the very same for everything else. So for us in Colorado, fentanyl is fourfold. First, it's sometimes being found in cocaine and meth. That is extremely rare. That's accidental cross-contamination on the scales. Fentanyl powders here, that's a little newer to us. Primarily it's being pressed into pills called the blues. There's a little fentanyl, a lot of fentanyl, or no fentanyl in those pills. My folks are smoking between 5 and 20 per day. Now, There are some benefits to smoking. Smoking is risk reduction over injecting. Anytime you break your skin, you're at risk of infection. Stigma reduction, right? Smokers think they're better than injectors. People who drink think they're better than everybody. And then you've got that fourth tier of people who want oxys or Xanax, but legislators have legislated us out of a safe supply of pills. So it's not like people are like, no, thank you, good sir, we shan't be having pills. They go to the streets and get the same unpredictable drug supply as everybody else. So some of that misinformation, we want to make sure you have good information. Fentanyl and fentanyl analogs are not naloxone resistant. They are opioids and will respond to naloxone in the event of an overdose. You cannot overdose by touching fentanyl. That only seems to happen to cops, right? Those have all been debunked as panic and anxiety attacks, but the chiefs don't want to come back out into the media and embarrass the officer. So much so, the American College of Medical Toxicology and the American Academy of Clinical Toxicology released a joint statement about that. Just seeing if you need anything from me. Boop, boop. Oh, and fentanyl and meth. Yep, we'll definitely get there. Um, it's not being found in cannabis. You can't really vape fentanyl. Fentanyl can only go into a vape at 477 degrees. Most vapes only go 225 to 250. Now, the way that you smoke it is really it's being vaporized. So say you have a foil, you have your blue on there, you have the heat source underneath, and you're kind of vaporizing it from a long straw or pipe. So I see why people think that's the same as vaping. It is not. Folks have asked if they should be afraid of overdosing by inhaling secondhand smoke of a person who's smoking fentanyl. Smoking is an effective route of administration for many drugs because the fat dissolvable molecules can pass into the lung cells, then into the blood very easily. This means the exhaled smoke contains very little of the actual drug itself. And I want to be really clear, nobody asked for fentanyl. It is very, very, very sedating. Everybody misses heroin. So most people that use fentanyl have to have a meth or a stimulant on board as well to be able to function and push forward. But to the person's point in the chat is, drugs are synergistic, meaning it's usually not 1 + 1 = 2, is 1 + 1 = 4. So poly drug use puts people at higher risk of overdosing. Also, in our current fentanyl supply, we are seeing other drugs. So we're seeing a little bit of xylazine. Xylazine is a veterinary sedative. Xylazine kind of makes sense why it would be in the fentanyl. Fentanyl so shorter acting. It allows it to be longer acting. That's important for folks because again, if I was a maintenance heroin user, I wouldn't be in withdrawal, which is physically painful to flu times 1,000 for 4 to 6 hours. Fentanyl shorter acting, which means that's why you get it when you have a colonoscopy or give birth. It's after an hour and a half, maybe 2 hours, you're in withdrawal, which is physically painful. So the xylazine actually lengthens that euphoria. Now, xylazine doesn't cause wounds. Anytime you break your skin, you're at risk of infection, but it's a vasoconstrictor, meaning it doesn't allow for scabbing. So there's a lot of necrotic tissue issues. Nitazines or nitazines are here. That's a new class of synthetic opioids that may replace fentanyl altogether. Medetomidine is coming, and it's here just a skosh. That will probably replace xylazine. That is also a veterinary sedative, which will lengthen the euphoria of fentanyl. We also have parafluorofentanyl that's here. That is a fentanyl analog. We also have BTMPS. BTMPS has an industrial use as a UV blocking component added to plastic and as a fragrance in candles because we believe they probably are using BTMPS to make as the precursor to making fentanyl because all opioids are going to be made synthetic and in a lab for the rest of our lives. Because it's called the iron law of prohibition, the harder the enforcement, the more potent the drug, lather, rinse, repeat. We're going to have an unregulated and unpredictable drug supply for the rest of our lives if we don't do something about it. Do I have some ideas? Of course I do. People who use drugs and healthcare providers have a very tumultuous relationship. I actually get more referrals to my program from the police department than I do from any of the hospitals combined, which is weird. But law enforcement knows they can't erase their way out of drug use, or they simply would have already done so. So this is a survey we did with some healthcare providers a few years ago, talking about challenges and opportunities of working with people who primarily at that point inject. 136 clinicians didn't know where to send patients to access harm reduction services. We're like 3 blocks away from Denver Health and Hospitals, so we were like, oh, okay, you should know this. 97 clinicians felt they needed to prioritize connecting patients to treatment over harm reduction. That is very tricky in a hospital setting. The only thing you can really get is Suboxone. Suboxone is medication for opioid use disorder. Suboxone was really made for heroin. It wasn't really made for fentanyl. The gold standard for treatment for people who use opioids is methadone. However, methadone is in clinics that are run by the DEA with DMV's customer service. So we'd like to see methadone out of the clinics and into the pharmacies because that is the gold standard. There's virtually no treatment for stimulant users, people who use cocaine, crack, or meth. What we've found for unhoused folks who use stimulants chaotically, housing is actually treatment because you don't have to use this chaotically in the winter, in the middle of the night to stay up if you have a safe place to be. 154 clinicians deferred harm reduction conversations to social workers or similar staff at the hospital. I don't really have access to that staff. 72 clinicians felt they don't have enough time to discuss harm reduction with patients. And 34 clinicians agreed, and an additional 33 were unsure whether people should be put in jail or prison if they are caught with illicit drugs. Are you a nurse? Are you a cop? So we don't support drug testing either because there's so many false positives in drug testing. And the Marshall Project has done a really good job of getting some stories together. I mean, they're starting to drug test people who have given birth in the hospital, and then they're reported for the positive drug test of the drugs they were given in the hospital. So it's like it's a true cluster out there. And we could be doing so many other things besides UAing people. So we did pass a statewide legislation last year to reduce warrant checking in the emergency departments and in hospital settings. That was really happening a lot in Denver, so I assume this has been happening a lot around the state. We finally figured out what the deal was. So healthcare providers, as we all know, are mandatory reporters, so they need to mandatorily report gunshots, stabbings, kid stuff. We all know that. But and as part of their section C, it stated any other injury the licensee has reason to believe involves a criminal act. So what was happening is nurses were reporting small amounts of drugs or paraphernalia to security. Security called in law enforcement warrant checks somebody. Everybody's got a warrant, goes to the jail. You're not going to get quality health care in jail. They go back out into the street, and all that does is tell other people don't go to the emergency department for quality health care. So we were able to reduce that in saying, other than the possession of drugs and drug paraphernalia. So people can now access quality health care in the emergency departments and hospital settings across the state. Now, step one is passing laws. Steps 2 through 10 are all about the implementation. So we don't have that many great avenues to get all healthcare providers updated about this, but it's important we have one conversation by one conversation. If anybody on here is friends with folks that are in, well, I'm assuming they'd be roommates, middle school or high school, you definitely have to talk about fentanyl. You definitely need to talk about the pills. We're a very pill popping culture for years and years and years. Mom's a nervous flyer. She takes a benzo. But you can't really pop pills anymore. That's, it's just a very unregulated supply. So that's a lot of times where we lose those 10 to 18-year-olds. This is a safety first curriculum. This is a free curriculum for middle schoolers and high schoolers. Because right now, if we don't talk about drug use, much like the sex, it makes it high risk and undereducated. So we've been an agency right here in Denver for 23 years. We've had the ability to legally exchange syringes for the last 14. We've been giving out pipes for about the last five-ish. This is just us at our current location we've been at for 6 years. Access episodes are every single time we're engaging with folks, creating a relationship where they can dispose properly of used syringes, access to sterile syringes and pipes, and then every single time offered referrals. Do you want to talk to staff today about Medicaid enrollment, mental health, substance use treatment, naloxone, health education classes, HIV, Hep C testing, fentanyl and xylazine testing strips? Last year, over 13,000 times folks said, yes, I want to talk about a referral today. What are my trickiest referrals in town? Same as yours, mental health and substance use treatment. I'm the largest provider in the state that works with people who use drugs, and I can't get people into treatment today, and that's a problem. After reviewing all the research to date, the senior scientists in the Department of Health and Human Services and I have unanimously agreed that there is conclusive scientific evidence that syringe exchange programs, as part of a comprehensive HIV prevention strategy, are an effective public health intervention that reduces the transmission of HIV and does not encourage the use of illegal drugs. If we were all together, I'd say shout out what year he said that. 98. Welcome to the late 90s. And actually, we've had syringe access programs in the United States since 1987. The first one was in Tacoma, Washington. So this is us at all four locations we've been at over the last 23 years. We do not own anything. I thought we could purchase our current location for 1.85 million, which would have been a lot for us. Across the street's land sold for 12 million. They must have laughed at my 1.8 million dollar ask. So we're gonna have to move again, which sucks. But thankfully, we're an award-winning neighbor. This is what it looks like inside. There's no good media representation of a syringe and pipe access programs. People assume we're a dark and dingy home with toddlers running around or something like that. We are open Christmas Eve, Christmas Day, New Year's Eve, and New Year's Day. This is our overdose memorial wall. This is our why. It doesn't have to be like this. People don't have to die of preventable overdoses. We just have the audacity to believe that people shouldn't have to die of a preventable overdose. So in all 40 states and 93 countries around the world, programs look a little different. Sorry, I'm getting a little chilly. Although I heard it's going to be 80 next week in Denver because I don't know where that winter went, global warming. Am I right? Okay. So Monday through Friday, 9 to noon is the syringe and pipe access. We have access to on-site service providers. So just because folks work with those that are unhoused or have mental health issues doesn't mean they're a harm reductionist. So when we allow a service provider in here, we're co-signing the fact they're going to be nice to you, right? So we've got somebody that helps with mental health services. We've got housing that comes in and out of here. We have a methadone clinic that comes in and out of here to do intakes. We also have St. Francis Center that comes in that helps folks garner IDs, birth certificates, social security cards. We try to be as one-stop shop as possible. People who use drugs are the true first responders in this overdose and prohibition crisis. They need access to naloxone first and foremost. Anybody in the state has been able to carry naloxone legally since 2013, so for the last 13 years. We have fentanyl testing strips where folks can test their drugs to see if fentanyl or fentanyl analogs are present. We have xylazine testing strips for folks to test their drugs to see if xylazine's not a present. We have an active people who use drugs advisory committee that talks about what's going on in the community, what's going on in the agency, and how we can push forward together. 7 of the 11 of my current staff are current and former people who use drugs. 8 of the 11 are currently or formerly unhoused. Access to mail and phone. Again, we passed 8 pieces of statewide legislation and made 4 Denver city policy changes. We do street outreach in high drug traffic areas and encampments 3 afternoons a week. We do health education. People thirst for those factual health information. We have a leadership cultivation program that meets on Monday and Friday afternoons. We do a litter cleanup on Wednesday afternoons, participant led. It's one thing to say we're going to be a good neighbor. We have to show folks we're a good neighbor. Our folks are invested in the health and safety of the community in which we serve because we're that one safe space in the entire world. Folks can talk realistically about their drug use. We do tours and presentations. Again, there's no good media representation of a syringe and pipe access program. We also do on-site testing. We also do on-site hepatitis C treatment. 35 people have been cured from hepatitis C. It's completely possible. We also keep their medication on site. So, with medication every day, usually you have to eat with it. So people come in, get their meds, eat something, and bebop on. After about a month or two, when they're done, then they get that confirmatory testing to make sure that they've cleared it and cured it. And one of the last guys, when that happened, and he's like, "I'm cured." I'm like, "Oh my God, that's so exciting!" And he goes, "I need to use your phone. I got to call my mom." I was like, "Oh my gosh." We also do voter registration. Folks that are unhoused or transitionally housed need to be a part of community decisions, so they're able to get their ballots here. This is Mariela. She's our logistics coordinator, logistics director. We also do an inmate outreach program, so we write our folks that are incarcerated well-wishing and good health information. And then we're an award-winning neighbor. We just won so we won this award a few years ago. We just won another award. Oh my God, I hate to brag. Just kidding. I love to brag. Because I wouldn't even have the luxury of running a shit show, or Denver Police Department would be here all the time. You know who I don't want here all the time? Denver Police Department. So, oh, litter bugs. What a great and award-winning neighbor. My good night. So questions, issues, concerns before we transition to overdose crisis. Okay, Cassie, I'm going to transition, but if a couple come in the chat, I get it.
No, nothing yet. Just lots of claps and hearts and thumbs up. So I think we're good.
Oh, I love a clap, hearts, and thumbs up. Okay. Again, I cannot be more clear. We are in the worst overdose crisis we've ever been in with the most unregulated and toxic drug supply we have ever seen in the United States. There have been a little bit of dips nationally. Unfortunately, Colorado is one of 6 states that increased overdose deaths in 2025 over 2024. We are very upset about that. Grief is all I have left of you. So, yes, I do hold on to it. We had a lot of problems in Denver in 2025. We knew we were in a real pickle because you could say in May of 2025, we had 63 deaths, 58 in April, 62 in March. March and May were the highest that Denver has ever had for overdose deaths. I don't find out about overdose deaths for 12 to 18 weeks because of toxicology reports. I don't really care about the supply in 12 to 18 weeks of 12 to 18 weeks ago. So thankfully, we're just about to do some on-site drug checking. So we're hoping that comes up here pretty soon. But that's incredibly concerning. And as you can see, we're really concerned that there was 562 folks as of a couple weeks ago that died in 2025. My concern is it's going to go up over 598. The same has been seen about 1,700, so about 3% increase of what we know in Colorado has increased as well in 2025 over 2024. We're like, well, okay. So we will not have a final count until June. The problem is once we get a final count in June, nobody cares about the year before. So at least Denver has been trying to do a little more with getting some more real-time data. And then overdose continues to be the leading cause of death of our unhoused neighbors right here in Denver. And they are saying for the state of Colorado as well. And you could see in that March of those 62 people that died, 27 were unhoused. We can definitely be doing better than this. This is Vernon Lewis. He's our former overdose prevention coordinator. That is Hickenlooper, who was our governor, who's now our U.S. Senator. Vernon in 2017, I believe, trained Governor Hickenlooper how to recognize and respond to an overdose. These are 22 of my participants that died of very public overdose deaths in the last few years, outside, in alleys, in parks, and in business bathrooms. When folks are unhoused, they use outside, in alleys, in parks, and in business bathrooms. When folks are unhoused and inject, they'll inject first in a business bathroom for 3 reasons. One is you can close the door, the cops won't come up on you like they can in an alley. 2 is so the larger community and kids won't see them. And 3 is so they can have access to sterile water. All drugs need to be made as blood-like as possible to inject. When folks don't have access to sterile water, it doesn't mean they don't inject. It means they use toilet tank water, river water, or saliva. It used to be cops coming up on people overdosing, and everybody was fine with that. Now it's 17-year-old baristas who are being re-triggered every day because they don't want to clean the bathroom before they go home because they've come up on somebody overdosing. So the overdose crisis is a larger community trauma issue. And again, in March, like I said, I was really finding out all about these deaths, and I'm like, what the heck is going on? So there's 4 main reasons why people overdose. The first is the change in the quality of the drug. The supply is unpredictable. Second main reason is any period of abstinence, coming out of jail, prison, treatment, living a life of recovery. Folks coming out of incarceration are 129 times more likely to overdose post-incarceration in those first 2 weeks than the general population. The third main reason is mixing. So alcohol and fentanyl or fentanyl and meth. And then the fourth main reason is simply using alone by the very fact that no one's there to witness, recognize, or respond. So there's a difference between being really high and overdose. Really high is muscles become relaxed, speech is slow and slurred, sleepy looking and nodding, but will respond to a sternal rub. Versus overdose, it's a deep snoring or gurgling. It's called a death rattle. They say if you've ever heard it, you'll never forget it. A very infrequent or no breathing, the pale or clammy skin, the heavy nod, not responsive to stimulation, a blue or gray skin tinge of the lips or fingertips, depending on skin color, because an opioid overdose is lack of oxygen. We have the antidote. It's called naloxone or Narcan. It's safe and highly effective. Paramedics and emergency departments have been using it for over 40 years, which is really great if overdoses happen around paramedics or emergency departments. It needs to be in the hands of people who use drugs first and foremost, as they're the true first responders in this prohibition crisis, Anybody in the state can carry it. You can't get high from it. The only thing it can do is knock the opioid off the receptor and hold for 30 to 90 minutes. If people don't have opioids in their system, it won't do anything to them. So you can't mess it up, which is why they let us have access to it. There's no side effects except the precipitation of withdrawal, and it's administered intramuscular or intranasal. We do not support anything over 4 milligrams, and actually 0.4 milligrams injectable is the gold standard. So we want to make sure that we have a compassionate response. So it was created in 1961 by Jack Fishman and Moses Lewenstein. In the 80s and 90s, instead of giving it to people who need it most, people who use drugs, it was used exclusively by emergency personnel and in hospital settings. Now, there were a few sympathetic EMTs that were pushing it off the ambulances to give to people who use drugs. Then in 1996, the biggest badass that ever lived, Dan Big, out of Chicago, started giving people who use drugs naloxone for a few reasons. They have many legitimate reasons to not engage with EMS and 911, and in fact did so infrequently. They already employed a whole array of creative methods of reviving their peers that have been passed down through many generations. There was a easy to use, very safe, and extremely inexpensive pure antidote to an opioid overdose. We passed legislation in 2013 right here in Colorado. We started giving it out legally in 2012 here. Then from 2013 to 2015, physicians in the state weren't prescribing it at the rate we thought they should. So in 2015, we went around them. So orgs like mine could push it out without a physician present, or most major pharmacies were working under a standing order to push it out. Now you can walk into pharmacies and get access to Narcan intranasal over the counter, which is really great. So opioids fit exactly on the receptor, lock and key for my visual learners. Then naloxone bullies it off for that 30 to 90 minutes while we can rescue breathe for folks. So responding to an overdose, are you all right? Are you okay? Pain stimulus. If folks are going to call 911, what you want to tell them is do not say it's an overdose. Say someone's not breathing, which is true, because 9 times out of 10, you won't get the cops, because what we don't need at a medical emergency is law enforcement. So you lay folks out on the back, you go under the neck and close the nostril, 2 big breaths right off the top. Then you're going to do intranasal up one nostril and spray. Then you're going to rescue breathe once every 7 seconds for 3 minutes. You got to give the naloxone time to work. If they're not breathing after 3 minutes, you use the other dose and spray up the nose and continue rescue breathing until they start breathing. Training can be done by staff or pharmacists, including risk factors, recognition, calling 911, rescue breathing, and administration of naloxone. I just trained you, a little free gift with purchase today. Because most of our folks are reversing folks outside in alleys, in parks, and in business bathrooms. This is very public. Fentanyl testing strips. We'll test your drugs to see if fentanyl or fentanyl analogs are present. Xylazine testing strips will test your drugs to see if xylazine is present. Now, 2 lines are negative, 1 line is positive, which is counterintuitive to everything we've ever done, such as pregnancy tests or HIV tests. So it does take a couple minutes. Anybody in the state can carry naloxone. 204 law enforcement departments in the state carry it. Denver Police Department was first. Colorado Springs PD was second. And there's 8 county jails that train heroin and fentanyl users in jail how to recognize and respond to an overdose and put that naloxone in their property for upon release, because they know about that 129 times more likely to overdose post incarceration. That's Arapahoe, Boulder, Denver, Douglas, Larimer, Jefferson, Routt, and Moffat County jails. We're getting a lot of thoughts and prayers now about drug policy. Oh, nothing we can possibly do. Well, there's a lot. So these are the laws that we've passed. Anybody can carry sterile and used syringes as long as they disclose to law enforcement before they're pat down or their vehicle is searched. Anybody can carry naloxone. We've limited civil and criminal liability. Not only can people carry syringes, but they can also carry pipes, sterile and used. That is also a statewide law. We've reduced warrant checking in the emergency department. And sometimes people are like, do you have any data about that? I've got binders of data. Everything we do are evidence-based, data-backed interventions. What we're up against is people's tummies hurt, right? Like, ooh, I don't know. I don't know if you should do it like that. Well, we do, right? People are dying and they're dying of very public overdose deaths, and we got to go with what works. We've got the binders to prove it. Now, in 2022, there was a trash piece of legislation that passed in the state of Colorado that's been incredibly problematic. They did put some money in there for fentanyl testing strips and naloxone. That actually came from the Behavioral Health Task Force that met the fall prior. They had to put it in some legislation. They put it in this one. We now have fentanyl drug-induced homicides in the state, meaning every fentanyl overdose death is a murder investigation. You don't get the cartel that way. You don't get mid-level sellers. You get low-level sellers like friends and family members. That's mandatory minimum 8 years. Felonization of fentanyl at 1 gram, which is 10 pills. As you know, it's very difficult to house people with felonies within the last 7 years. Mandatory treatment, which is wild. It's hard enough to get into voluntary treatment. And OD mapping. Bob and I are hanging out doing drugs. He overdoses, and in good faith, I call 911 and stay with him, and he lives. Now my home or encampment is pinpointed on a map. And if too many people in my neighborhood call 911 for an overdose, we're going to get law enforcement surveillance. So in the worst overdose crisis we've ever been in, with the most unregulated drug supply we've ever seen, no one's calling 911. And why would you? Sorry, I'm trying to see this question here. Any data what causes the growth that we are seeing in drug use? Drug use has always ebbed and flowed, to be fair. I think a lot of times what we're seeing is, when we see youth dying of overdoses, again, I think it's the pills because they were, the traffickers were very smart to pump everything into pills because it comes in via powder and then it's made pills usually here domestically. I think that was probably a way to be able to traffic and shift because we're such a pill popping culture and nobody's really talked about the pills. I think that's a problem. Sometimes people think that there's a lot more public drug use. There's more public drug use for people who smoke fentanyl because it's very difficult to smoke inside because people, when fentanyl is being smoked, it smells like an electrical fire. So that is very difficult in particular. A lot of people who are unhoused or are housed will also use meth a lot too, because if you experience a lot of like depression, maybe meth makes you feel really great. And sometimes you don't want to feel like shit and you want to feel really great. So I think it ebbs and flows much like alcohol. The only luxury we have with alcohol is that it's a regulated supply, so we know exactly what's in that. We did had a large drop from 2022 to 2023 in the 911 calls in the overdose arena in the Denver metro area. I'm still trying to get other data from them, but we were concerned about that. We started having folks signing do not prosecute orders. In the event of their overdose death, they wouldn't want their seller prosecuted. Most people who use drugs are low-level sellers. And, by the time it gets to the street, nobody has any idea what's in their drugs. So we, the people who are most affected by all aspects of drug use and the war on drugs, will not stand by while our brothers and sisters are locked up, abused, and dehumanized in our names. This is the Safer Syringe Disposal Initiative. These are syringe disposal kiosks. They're about 4 feet high. If you've ever been to New York City, you've bumped into them all over the place. There are 20 in the state. There are 7 in Denver that allows for 24/7 proper disposal, which is really great. People living in chaotic drug use tend to be more successful at making positive changes in their lives if they first have their most basic needs met, like food and shelter, access to healthcare, meaningful connection, and being treated with dignity, regardless of whether or not they continue to use drugs and not contingent on if the difficult circumstances in their lives have changed. Okay, so for the next few minutes, I'm going to tell you where we're trying to go, and then we'll definitely open it up for questions. So right now, we can do everything to prevent and eliminate the transmission of HIV and hepatitis C, resources, referrals, naloxone, fentanyl, and xylazine testing strips, but it's not legal for them to use on my property. Use and possession on the property can get the property seized. So they go a few blocks away to an alley or a business bathroom, and they use there often alone. Not only are they using there, they're overdosing there. Not only are they overdosing, they're dying of overdoses in public places. So we are the folks pushing forward with overdose prevention centers. It would simply be a program arm of an already flourishing syringe and pipe access program, maybe on the southeast corner of 8th and Lincoln in Denver. The drugs are pre-obtained, meaning they're not bought or sold on site. People don't inject themselves or smoke. It reduces the acquisition of HIV and hepatitis C because all the equipment is sterile. It reduces skin tissue infections. It promotes proper disposal. It's now happening in 18 countries, 150 sites over the last 40 years. No one's ever died of an overdose at one of these places because there's a trained professional there to recognize and respond. And the same cannot be said for Starbucks, Jimmy John's, King Soopers, City Markets. Do I have a binder about it? Of course I do. The bottom, you can see it does not increase community drug use. It does not increase initiation into injection drug use. It does not increase drug-related crime. Folks are invested in the health and safety of the community in which you serve because you're that one safe space in the entire world. Folks can talk realistically about their drug use. And however you feel about it, we'll always have use sites on the left. I would rather mine were supervised and sterile. It's incredibly business friendly. We know that people are overdosing and dying in businesses. Legislators know that. Decision makers know that. They don't really care. So overdose prevention centers are incredibly business friendly. This is a physician out of New York City. He said we need to play that game. We will require politicians to finish every sentence denouncing supervised injection facilities with the phrase, and that is why I think injecting alone in McDonald's bathroom is better. He's fun. He's sassy. It's incredibly business friendly. We've got docs, we've got nurses, we've got organizations. Treatment and recovery love it. The number one substance use treatment admission requirement in the state of Colorado is that people have to be alive. I don't make the rules. We have religious supporters, especially churches, because churches are some of the only unlocked bathrooms in town. Former Colorado Attorney General Cynthia Kaufman, when she was in office, was very supportive. And then we need to have a real conversation about a safe supply, a regulated opioid, a regulated stimulant. People have used drugs forever and ever. People will use drugs forever and ever. We just have the audacity to believe that people shouldn't have to die of a very preventable overdose with a very toxic drug supply. Alcohol isn't legal because it's safer. It's safer because it's legal. Just as a safe supply of alcohol was not meant to solve all the problems of alcoholism, it did provide the starting point, eliminating the need to correct the many problems created from it being illegal. Safe supply works towards ending the criminalization of the vulnerable through drug policy. Safe supply brings back the possibility of hope, stability, and dignity for people who use drugs. It will not be a cure-all or a magic bullet, but it is a necessary component of ending the war on drugs that has done so much to divide and harm our society. Those who are truly invested in ending prohibition will make expanding safe supply a top priority. If every single time we had a safe supply in a use site, happy hour, the waitress asked us if we wanted to get into treatment, we'd be like, what did she just ask us? It's chaotic and non chaotic relationships to drugs, problematic and non problematic, just like alcohol. It's currently happening in 7 countries. Of course, I have a binder about it. There's actually quite a few countries around the world that do syringe exchange in prison. Knowing every single jail and prison in the world that drugs get in, they want to make sure that folks don't acquire HIV and hepatitis C. And this is me, your local harm reduction freak. Questions, issues, concerns.
As folks are thinking about questions, Lisa, thank you. That's so much information. I think the first email's in the great, thank you, email in the chat. Folks will have that for Lisa. We can put that in the recording as well. My biggest question is how do folks who are focused on housing build in these components of this, longer term treatment, creating these safe spaces? What are maybe some simpler, more bite-sized pieces that folks can start to do in their day-to-day as they're housing folks?
I appreciate that. So everybody walking on Earth needs to be carrying naloxone. It is possible in the state of Colorado. We need to be also giving it out to folks that are in your housing units. They also walk around the state of Colorado and you need old hands on deck. If people, people are using, it's very, very dangerous to use behind a locked door. So we all know that a lot of times people who are unhoused stay oftentimes in encampments so they can save each other's life if they overdose. Once they get housed, you'll see that people sometimes aren't flourishing and end up overdosing behind a locked door. So we want to be able to have real conversations with folks. Maybe if you have an advisory committee of participants at your housing units, talk about what that looks like. How can we be a safer and healthier community? Fentanyl testing strips. If folks, just because they don't use opioids, they might be using cocaine. We want to make sure they have good information. What does treatment look like for folks? It's very easy to say, go to inpatient. Inpatient's not that easy to get into. We have social detox, we don't have medical detox, and some people are so afraid of losing their housing. So you won't see a lot of people ask you for inpatient because they're so afraid that if they go to the inpatient, they will be discharged unhoused, which is terrible. If they are using opioids, methadone and Suboxone, again, are the gold standards. Methadone more than Suboxone, but both are the gold standards. being supportive to that. If your community does not have a methadone clinic, that is a problem. Methadone cuts overdoses in half right away. So we want to make sure that you are also advocating for good treatment options. It is very difficult to tell people to get into treatment when we don't have good treatment options. So having people with lived and living experience at the table when, in a Southeast Colorado is having that conversation or thinking about putting in a service provider, we need to be more supportive to that as well. And then lastly, I would say reducing that judgment and stigma. Again, if stigma, shame, and incarceration worked, we'd have just truly wrapped this up years ago. All stigma, shame, and incarceration does is push drug use underground. And when you push drug use underground, it's truly dangerous.
Great. Thank you. Are there any questions in the chat? Now I'm sharing my screen. I can't see anything. So if folks want to put questions in, please feel free. I do have another one. We have time for a couple. So does one of my,
So
I think she, go
Paul
ahead.
put something in there. Shout out to Western Colorado Area Health Education Center for Delta and Montrose. Yes, yes, yes. And naloxone dispensers and the organizations that allow success to help reduce overdoses in our area. Yes, thank you. I also forgot to mention that Durango also does syringe and pipe distribution in Grand Junction. So thank you so much, Paul. Heart, heart, heart. Calissa, okay, we're best friends now. Just Calissa says some really great stuff that we're just best friends. So don't worry about it, everybody. Calissa and I are besties. Thanks, babe. Any other questions?
I have
That is,
one more. I have one more if you don't mind. And
it's not that.
I'm sure that you get this a lot. We are working statewide. We're working with a lot of small rural communities where housing, homelessness, drug use, all of this is just kind of crashing onto them at one time.
I know we're all under
Um,
attack.
yeah,
They're
it's a lot. It's a lot. I'm curious if you have any words of wisdom for how to start those conversations with people who need to be on your side, but might not be on your side. We're not trying to change everybody's mind, but we are trying to change the impact of programming.
That's exactly right. You got to get your low hanging fruit first. I have found like law enforcement was really easy for me, honestly, because they know they can't arrest their way to drug use. And a lot of folks have been pricked by a needle. So those conversations, I can't have them in like a large room of folks, but one conversation by one conversation. And that really is what harm reduction movement and the housing crisis movement is one conversation. Because everybody's like, what about it? Or I'm going to be a devil's advocate. And it's like, great, that's cool. Every devil needs an advocate. That's awesome. But really talking to people, is it about the cost benefit analysis? Is it because, we believe that people shouldn't die? Is it because we don't want 17-year-olds to have to find dead bodies? Is it because we don't want cops getting stuck by a needle? Is it because we don't really have the treatment industrial complex that everybody thinks? So I always let other people kind of veer the conversation. I never say anything that, I don't know, right? So a lot of times I'll be like, great, like, oh my gosh, I've truly never heard that one before. I'll definitely get back to you. Definitely everybody take down my email because you know me, I have binders of data. I don't need it. I know this works. We would need to push it out to folks. So if you get into a conversation with somebody, you're like, you know what? Let me go talk to somebody and get back to you. I'll send you a ton of stuff where it's like, oh yeah, how about this? Oh yeah, how about this? Sometimes people don't, and we all saw from 2020 that people don't believe in science and data. And it's like, oh, well, what the fuck? I don't know really what to tell you on that one. But because everybody's an expert, and it's like, well, here's what we know from the data, right? Always bringing it back. Here's what we know with people who currently use drugs or those that are living a life of recovery. A lot of times people love a good treatment and recovery story. How do you think they get there? Have you ever been to a exchange program before? Do you know where one is? The best compliment we can ever receive is they had no idea we were located here. That's exactly it. We are just public health in your community. Everybody needs to carry naloxone. People are like, oh, naloxone enables. Naloxone enables breathing, friend. And enabling is such a weird term, too. Enabling people for healthier and safer them to engage with resources and referrals and expertise and people that are rooting for them, then yeah, I guess we are enabling. It's not a crime to be kind to people. So the grief of losing so many people has made me angry. Don't worry, I try to play the game and I do a much better-ish job with decision makers, but sometimes you got to speak really sharp and stern with people. That's how they learn. Colin?
Yes, thank you, Lisa, for being here today. This has been really, really incredible. Always been a big fan of the Harm Reduction Action Center, so
Thanks, Frank.
appreciate the opportunity to learn from you. I think on a similar but slightly different line, we know from HUD that substance use and treatment is going to be a big part of the funding priority for releases of funding opportunities moving forward. And there's obviously a lot of power in harm reduction in that space, but there's also an aversion to the words harm
Yeah.
reduction. And so, do you have any tips and tricks in terms of messaging, in terms of how can organizations use this as an opportunity to sort of, re-envision how they engage the
Yeah.
substance use population without sort of using the buzzwords that are going to activate some of that backlash or concern.
Thanks, Bestie. I appreciate that. Yeah, what a terrible fascist regime in which we all live. And I know that you guys are really struggling with that in the housing sphere. I had somebody be like, "Are you going to change the name of your agency?" And I was like, "No." But because if we stop saying it for us, then they win. But for you, it's really important. So risk reduction, overdose prevention, withdrawal management, things where it's like, okay, that you're really doing that. Because we also don't want to denigrate harm reduction or kind of what we're doing here. So I really appreciate you bringing that up too. But there are some folks, and actually, Cassie, what I'm going to do is I'm going to email you afterwards if you could push out to the attendees. And Cullen, I have a really good messaging guidebook from Drug Policy Alliance that I'll attach to that because I know that they've done a lot of work in the space too. And I want to make sure that we're not missing anything with them. But the risk reduction, withdrawal management, and the overdose prevention, I know are right off the top. But I want to make sure that you have all the information that you need to be able to push forward with the all the barriers that you all are seeing too. So I'll definitely make sure to do that. As part of that, Cassie, too, sending out to the team, I also do a monthly newsletter. So if anybody would want to receive one, I write it when I'm watching Real Housewives and drinking mimosas, a safe supply on a Sunday morning. So they're a little sassy, which people love. But just to get good information out there, state of the state on drug supply, new messaging and stuff too. And there's also going to be a terrible, terrible, terrible ballot initiative. Oh, Stephanos, thank you. A ballot initiative that's going to basically, if you look at fentanyl in the state of Colorado, it's going to be a felony. A sale of one pill is going to be mandatory minimum 8 years. That's going to be on the November ballot. The problem is they're going to have to build a new prison per year for the next 5 years. And it's like, what are we doing here? And unfortunately, that's going to the voters, which is not where I would bring drug balls. So there's a lot that we can all do together. So I will definitely, Cassie, make sure
Yeah.
that you get information on that for sure.
Yeah, no, that's fantastic. I would really appreciate that. We can share that out and post it as well. I am going to transition to the survey, Colin, give you a second to launch it and do all of that. And then Lisa, while folks are filling out the survey, we might have time for another question or two. That works.
Okay, one or two questions, friends, that aren't filling out the survey. Oh God, the survey's right in my face too. Oh my gosh.
It's one of the things about Zoom. It's right there. Um, and then yeah, Colin, just correct me if I'm getting this wrong. We'll do submit the survey. We'll send it out in a Survey Monkey after the call. You do get that chance to win a $5 gift card. And I don't know how many gift cards have we sent out now? Probably close to
Quite a few,
10.
and I would just express my appreciation for folks who do consistently do the evaluations. It really does give us helpful feedback. We, in our biweekly team calls, like reflect on, oh, here are things that have worked particularly well. Here's some places where we've gotten, feedback on areas to improve. And so just really underlining the importance of filling it out. I know that you're inundated with requests for surveys and for data all the time, but we do try and make good use of it. So we appreciate it and um, hope you all are able to express your hopefully satisfaction with the event. But if not, give us some info to go off of to learn more.
Any other questions that are coming through in the chat? If not, I do have another one for Lisa, but I don't want to monopolize the time. Okay. All right. Lisa, this is kind of maybe an interesting one. You've mentioned a couple of things that could be the answer to this question. Having naloxone, finding the commonality of pain points of these policies. What's one thing you wish every housing provider knew about the work that you do?
One thing. That we're rooting for people just like you're rooting for people. And I think we're on the same team and everybody needs somebody rooting for them. And so just because, we're not out at tabling a lot of stuff because can be really hateful to us doesn't mean that we aren't so pumped for our folks who are flourishing and getting inside because that's where people deserve to be.
I like that. That's a good note to kind of end on. We're all in this together, really trying to help folks.
That's
Any
right.
other questions coming in the chat? Anything else that's coming up? Any final words, Lisa, of great wisdom that you can share with us today?
Babes, I love you so much. Thank you so much. Please vote no on that ballot initiative. I'll get you more information. But thank you so much. Please don't hesitate to reach out. Questions, issues, concerns. I'm your gal.
Awesome. Thank you, Lisa. Thank you for taking the time. We really appreciate you being here. We know you've got a lot on your plate. So thank you so much for that. I'm going to move forward, I think. There we go. Oops, too far. Just a couple of notes about things that are coming up. We do have a few more curricula coming up in the next month or two. So at the end of March, we're going to be talking about best practices in emergency shelter. In April, we're going to be talking about some administrative challenges for folks who are first-time federal applicants or who are trying to expand their funding sources as Thor goes away. Later in April, we'll talk about Colorado HMIS tracking and how to use that amazing system as efficiently as possible. And then in May, we're going to be doing some peer program learning around rapid rehousing. So all of this is available at the website and at the QR code linked here. And we'll be sending out emails and all of that great stuff like we always have been. But as always, if anything comes up, please feel free to reach out and let us know. I'm going to end the poll now, Colin, since we've got about 2 minutes left. Anything else from the SHG team, from Lisa, from any participants today that we want to end on?
This was really great. So thanks. Thank you, Lisa. Thanks, everyone.
Absolutely. All right. Thanks, folks. I'm going to stop our recording now and we will talk to you all soon. Thanks, everybody.
Thank you.